Today, we're diving deep into a subject that's probably crossed your mind at some point. We're going inside the mind of a radiologist to figure out how they solve one of the most common and, let's be honest, stressful mysteries in medicine. What is that lump?
Yeah, it's an experience that's almost universal, right? You find some small, unexpected bump and your mind just goes there. It jumps right to the worst-case scenario. And that jolt of anxiety, it's powerful and it is incredibly common.
So for us, it's a moment of fear. But for doctors, that fear gets channeled into a complex diagnostic puzzle. And one of their best tools for looking inside the body to get a really clear picture is, of course, the MRI. But, this is actually where the real challenge begins.
So let's get into it. The mystery of the lump. What exactly makes diagnosing these things so tricky, even when we have this incredible, advanced technology at our fingertips?
Well, here's the absolute core of the problem. When a radiologist pulls up an MRI of a soft tissue mass, most of them, whether they're benign or malignant, look pretty much the same. They show up as bright on a certain type of scan, a T2 weighted image, and they all tend to light up, or what they call enhance, when a contrast dye is used. It's kind of like trying to find one specific person in a massive crowd where everyone is wearing the exact same clothes.
So if everything looks the same, how on earth do they ever make a diagnosis? Well, this is where the real genius of radiology comes into play. It's not about what you see, it's about knowing what to ignore and what to zero in on.
Get this. It turns out that only about 20 to 30% of soft tissue masses can be accurately diagnosed just by looking at the MRI. Now, I know what you're thinking. That sounds like terrible news, right? Like the technology isn't all that great. But actually, that little number is the key to the entire diagnostic strategy.
And that's the secret right there. See, because radiologists know they can't possibly identify the 70 or 80% of tumors that look generic, they don't even try. Instead, they become absolute experts at spotting that 20 to 30%, the exceptions, the ones that have unique visual fingerprints that totally give them away.
So you can really think of it in two buckets. On one side, you've got the huge majority of masses, all bright, all enhancing, a sea of sameness. But on the other, you've got this much smaller, much more manageable group of exceptions. These are the ones with special clues. Maybe they're dark when they should be bright, or they're in a very specific location, or they contain something weird like fat. Radiologists are basically detectives, and they're hunting for these exceptions. And if we're going to stick with that detective analogy, then this whole approach is kind of like a criminal investigation. So let's get to know some of the usual suspects, the tumors that have those telltale fingerprints. Okay, first up in the lineup is a common one. Its official name is pleomorphic undifferentiated sarcoma, which is a mouthful, but a lot of radiologists still call it by its old name, malignant fibrous histiocytoma, or MFH. So for our purposes, we'll call this one the old-timer. So what's its profile? The typical victim is an older patient. Its preferred location, its turf, is central in the body. Think deep in the thigh or the upper arm. And its MO, its method of operation, is that it breaks the rules. About half the time, it shows up dark on those T2 scans when pretty much every other tumor is bright. That's a huge clue.
So how do you even remember that? Well, the clue is hidden in plain sight, right in the old name. The word fibrous makes radiologists think of scar tissue. And what does scar tissue look like on an MRI? Yep, it's dark. It's a simple little mental trick, but it's an incredibly powerful tool for spotting the specific answer.
All right, next up, we've got a totally different character. Let's meet suspect number 2, Synovial Sarcoma. And we're going to call this one the young imposter, and you'll see why in a second.
Now, this suspect has a completely different profile. It usually goes after younger adults, say between 20 and 40, and its location is out on the periphery, so often near the foot, the ankle, or the knee. And its MO? It's trickery. It can sometimes have something called a triple sign, with high, medium, and low signals all in one mass. And it's famous for being mistaken for a simple Baker's cyst behind the knee. A good radiologist knows that not every lump behind the knee is just a harmless cyst.
Now, not all suspects are total strangers. Some, like fatty tumors, kind of exist on a spectrum. You've got your simple lipoma, which is totally benign, super common, and usually right under the skin. But then you've got its evil twin, the Liposarcoma, which is malignant. The clues? Well, it's usually found deep inside the body, it gets really big, and on the MRI, it just looks way more complex, with these thick, chunky divisions running through it.
So far, we've been hunting for the dangerous characters. But sometimes, the biggest challenge of all is correctly identifying the ones that look dangerous but are actually totally harmless. These are the classic cases of mistaken identity.
And that brings us to this really critical concept called don't touch lesions. These are things that can look super aggressive on an MRI, totally mimicking cancer, but they are completely benign. And the name itself is a command. Do not biopsy them. A biopsy could be misleading and might even lead to unnecessary and harmful treatments. Recognizing these imposters is one of the most important jobs a radiologist has.
So here's a classic example, myositis ossificans. This is basically just bone forming inside a muscle, usually after an injury. Early on, the MRI can look terrifying, tons of swelling, lots of enhancement. But the key is to get a follow-up X-ray or CT, which reveals its classic fingerprint, a ring of calcification around the outside with a clear center.
Next up is an avulsion injury. This happens when a tendon or ligament yanks a little piece of bone off. You see it a lot in young athletes, often around the pelvis. And the body's healing response can look incredibly aggressive on a scan, but it's just powerful healing, it's not cancer.
And one more great example is the cortical desmoid. This thing shows up in a very, very specific spot on the back of the femur bone, right near the knee. It seriously looks like something is eating away at the bone, but it's not a tumor at all. It's just what's called a tug lesion, and it's caused by the normal pull of a muscle that attaches right there.
So, okay, we've seen how radiologists are basically detectives, sorting out the real culprits from the innocent imposters. But why does this super specialized skill matter so much in the grand scheme of things?
Well, it's because every single one of those clues they uncover on an MRI scan has a direct, real-world impact on a patient's life. Getting that imaging diagnosis right is the first and maybe the most critical step toward getting the right treatment. Or, in the case of a don't touch lesion, getting the right non-treatment.
You see, a good radiological diagnosis is the roadmap for everything that comes next. Does the patient even need a biopsy? If they do, the radiologist works hand in hand with the surgeon to plan the absolute safest route for that needle to go to avoid contaminating any healthy tissue. The probable diagnosis helps the team decide if something like chemotherapy is needed before surgery. It guides the entire team.
When you really think about it, the ability to read these subtle patterns, to tell the difference between a healing injury and a deadly cancer just based on shades of gray, it's an absolutely incredible skill. And it kind of leaves you wondering, what other hidden stories, what other secret fingerprints are just waiting to be read inside all of our bodies?